Greetings, I'm Dr. Chris Apfel, and this short video should help you to get an idea of who we are and what we are looking for. A couple of years ago, my dad was diagnosed with lung cancer, and he refused therapy because when he took care of my mother, who had ovarian cancer, and the treatment did not work in her last months of life, he said to me right away, unless you can prove to me that this is going to work, unless you can guarantee that the therapy will not make me just worse, I don't want it. That was for me the rude awakening. I was not aware that in the majority of cases we actually don't know what the most effective therapy is if a patient gets diagnosed with cancer. The idea to personalize therapy has been around for a while, and a lot of money has been invested in genomic testing, and it's now often called precision medicine. And yet, only 1 out of 4 patients have mutations that we can use to use a targeted therapy, but even then, the response rates are not guaranteed. So, most importantly, genomic testing cannot predict response to chemotherapy. So most cancers are not responding to chemotherapy at all. And so I felt there must be a better way. Somebody needs to step up to the plate to make sure that patients can actually get the best possible treatment that they deserve. The only way to really predict what would work is actually to look what happens. And we therefore think it's actually not appropriate just to take a tissue sample, throw it into formalin, and then look for certain molecules what might work, because the cancer biology is much, much more complex. In a way, simply speaking, the whole is much more than the sum of its parts. And I will not explain all the zillions of pathways that are happening in an individual cell or cancer cell, but this gives you an illustration that you have the DNA in the nucleus, you have the RNA, the ribonucleic acid, that is actually the gene expression that interacts with proteomics and metabolomics. And as you can see, a whole living organism is much more complex, so that it cannot be properly characterized with just a few molecules. Instead, the most effective approach to understand what would work is if we take a fresh live biopsy and replicate these tissues in vitro to understand which therapy is likely to be most effective. And that's what we have developed. We have developed a tissue culture technology so that we can look in vitro which drugs are most likely to work in that individual patient. We can see here the untreated microtumor replicates on the left side with green stained cells reflecting viable tissue. And we can also see when microtumor is disintegrated by chemotherapy, as a result that there are a lot of red stained nuclei that actually reflect the dead cancer cells. What we also know is that this is dependent on the dosage. And you can see here on the left side the curve that illustrates a tumor that's resistant to a certain therapy. If you cannot kill the tumor and the viability of the cells stays at 100%, even if you give a dosage that is close to or higher than the maximum therapeutic tolerable dose, then you actually can know this cannot work in a patient. If you can't kill the tumor in vitro with very high drug dosages, you will not be able to do this in vivo. Conversely, if there is sensitivity, if you can actually reduce the viability in vitro significantly, you have good reasons to believe that this can also help patients. We translate those dose response curves to a bar chart so that even an oncologist can actually understand it, and you can actually distinguish drugs that are unlikely to work, those with the red bars, from those drugs that are more likely to work, that are illustrated here on the green bars. And I'll give you here an example of an ovarian cancer patient who has actually received neoadjuvant therapy, which is a therapy before the surgery, so you can shrink the tumor, so that you have better operative conditions, the operative trauma is not as big, and you have better outcomes. But unfortunately, even though in ovarian cancer the majority of patients respond to standard of care therapy, there are always patients, 10, 20, 30% of patients that do not respond to the neoadjuvant therapy and actually get worse. In this case, a lot of other drugs have actually been tried before. Carboplatin, paclitaxel are the standard of care drugs in this case, and they did not work at all. After all, after nothing else happened, the patient underwent surgery. We fortunately, based on the surgeon's request, not the oncologist's request, we actually got the tissue sample. We examined this, and what we found is that this tumor is really resistant against a wide range of drugs. Carboplatin, paclitaxel is typical, rucaparib and other PARP inhibitors as well, but also other second-line therapies. It would actually have been resistant, but we were able to find that actinomycin and vincristine could have been choices that actually could have reduced the tumor size and really helped this patient. Now we have developed this technology to a level where we can actually now commercialize it as a CLIA certified lab. We do not need FDA approval, and we are fully accredited by the Center for Medicare and Medicaid Services, even though CMS doesn't pay for the test. Now, this test can help many, many patients. It can help patients who are scheduled for surgery so that we can actually identify which one is the best possible therapy if subsequent therapy is necessary, so that oncologists can actually create superior care within standard of care. And then if a patient, the other alternative is has failed standard of treatment, is probably in a metastatic stage, we can actually look at those cancer tissue and provide and look for therapies that go beyond standard of care. And to give you a little bit more granularity here now on the left side, patients that are, for example, scheduled for surgery that are stage 2 or stage 3 patients, they most likely require additional chemotherapy afterwards. And there it would be important to test the tissue ahead of time so that we actually, or get the tissue from the surgery fresh before it's actually fixed into formalin, shipped to us overnight, so that we can actually examine it in our lab and see which drugs this tumor is responding most likely. And on the other side are the late stage patients with metastatic or recurrent treatments where previous treatment have failed. There we could, for example, get additional tissue from a core needle biopsy, or for example, of a liver metastasis of a breast cancer patient. Or we could actually also often obtain significant tumor tissue from an ascites or pleural effusion. These are fluids that accumulate in the belly or in the chest wall, and also these we can actually use for testing so that we can actually provide the patient and the oncologist with the additional information what might work best for that individual patient. None of this would have happened without a strong leadership team. My wife and I, we founded the company. I left my day job to make this work because we feel this is not fair. Patients have the right and should have the right to get the best possible treatment. So my wife and I, we actually started this company on our own dime. We have, thanks to angel investors, been able to stay afloat and bring this and develop this technology to its maturity. And we are now very proud that we also have other members that have joined the team, such as Dr. Kantz, who has been the president of the Society of Surgical Oncology and has also been the chief medical officer and the chief scientific officer of the American Cancer Society. There are other members as well that are really noteworthy. Dr. Arkel Giorgio, who has been the chief medical officer of United Health Group, and who has actually written a book on healthcare choices and has a podcast on Speak Up for Your Health, so that you actually inform yourself and that you take it into your own hands. We have now gotten some traction this year. We actually have been interviewed by Fox News in San Diego in connection with the American Association of Cancer Research Societies meeting in San Diego. And we have also been interviewed by other individuals, such as the Target Cancer podcast from Dr. Hugh Nesha. So what are we looking for? We feel that we need to find a way to get the word out so that patients are aware that there are other options. Because very often oncologists stick to what is standard protocol, and that often is not good enough. If you are diagnosed with a serious disease and the prognosis is not good, you cannot expect superior outcomes when you just get standard of care. You need actually to take your health into your own hands. You need to be proactive. You need to develop a support team. You need patient advocates who help you. You need to make sure that your loved ones and your relatives are on board. And you need to educate yourself what your options are. So what we are looking for now is a social media strategy. We need to develop that and develop also and execute on that so that people know about Sage. I also believe that we may need to do some search engine marketing. We don't know whether that our resources would be sufficient for that through either Google and or Facebook. We also need to generate explainer videos so that patients understand why it's so important to get the Sage Oncotest and why it can make such a big difference in their outcomes for such a very serious disease. I also believe that we need to improve our website. We need to also have some more resources there. It also needs to be more interactive, and perhaps with also some bots and chatbots, so that somebody could actually also ask questions, but also that actually forward the communication to us as it is needed. So with that, I would like to thank you for your attention. If you are interested in Sage, if you're interested, if this is important to you to make a difference to people's lives, I would love to discuss that with you, whether there may be an opportunity to work together and to develop a collaborative strategy so that we can really make a huge difference to patients. I think this can become a billion-dollar company, and my goal is to make this a billion-dollar company, not necessarily just because of the profits, but really because this is necessary in order to reach millions of cancer patients who deserve to get the best possible treatment so that they have a much better chance of survival and a much better chance of a superior outcome with less side effects. So thank you very much for your attention, and I hope this actually resonates with you, what I've just presented. Thank you so much.